All right, for those of you that are here, thank you for coming. We're going to have a conversation about workforce, and if it's anything like the last few conversations we've had, they go fast. So in the interest of using our 1 hour together well, and for you to have a chance to not only hear comments from the panelists, but to engage in a conversation, which I think is what makes ITUP more interesting and more fun, I'm going to go ahead and launch us off. So welcome. You are hopefully here to talk about the thing we have been talking about all day, actually, which is workforce. And I'm Sunita Mutha. I direct HealthForce Center at the University of California, San Francisco. I'll just say a little bit about that in a moment. And I'm the incoming board chair for ITUP. And delighted to be here with a great panel. The way we're going to do the session is I'll just do a couple of quick framing remarks, and then we'll have the panelists introduce themselves. We have really disciplined ourselves to keep our remarks short so that we can have a conversation with you. And I have a couple of initial questions for our panelists. I have one for them, and then we want to open it up. I want to hear, because when I look around this room, I see a lot of familiar faces. I see people who've been thinking about issues deeply around workforce and looking at solutions. And what we're interested in today is not the hand-wringing that many of us do about shortages and burnout, which is real, but we want to talk about where some bright spots are. And we want to talk about the issues around how do we spread, how do we scale, what do we do, what's worked well, and what might we do more of. So that's the conversation. Let's see. Okay. So here are our great panelists, and we will go pretty much in that order for our comments. And let me just tell you, several of you, some of you, maybe more than some of you, don't know very much about HealthForce Center at the University of California, San Francisco. So I just want to take a moment to do 2 quick slides of things that may be of interest to you. The first is, we've been at this. At HealthForce Center, we have been at this for more than 30 years. And we partner very deeply with the Institute for Health Policy Studies, our sister organization also at UCSF, who's been at this for 50 years. Not always in workforce, but together, this is what we have focused on. And if you look at this slide, which sort of tried to encapsulate what have we worked on, what kind of workforce issues, what impact have we had when that's been possible, that's what you should see here. We look at all of the workforce. We are not focused or committed to just one profession. We are deeply committed to ensuring that the workforce is healthy, it's adequate, and that we understand and that we have the evidence to really inform both policy and changes that need to happen. So that's what you might see over there. And you can see, if you glance at it, that there has really been an evolution. And I think we'll hear some of that evolution today, which is really looking at expanding who we think of when we talk about who's in the workforce, who's helping provide the services that our communities need, and really trying to understand issues around, does our workforce represent the communities who turn to them for care? Because we have such strong evidence that when there is matching, either around language or what we call racial concordance, when the person who is providing your care understands you, maybe even looks like you, we know that health outcomes are better. So that's the kind of underpinning of all of this. The last piece, for some of you, you may be interested, we have a behavioral health webinar coming up. Behavioral health has been a big topic all day today, yesterday as well. So if you want to take just a quick picture of this, you'll see ways to sort of sign up to understand what's the state of the evidence on that workforce. We also at HealthForce have a group that is bringing together those 2 really important members in the delivery system with CalAIM, community-based organizations and health plans, and others who are delivering healthcare services with our California Improvement Network. And then if you're wondering, what do things really look like? We haven't talked today at all, for example, about oral health. We know it's connected to everything else in addition to behavioral health. And you can see some examples of the kind of information that my colleagues have been working on to really increase our understanding so that we can take action, because that information is absolutely necessary to do the hard work that's ahead. What I'd like to do is I will acknowledge a few things. I said already that it isn't just workforce shortages. It is not just one group. Burnout is real. Wages are an issue. The cost of care is an issue. So I'm using that framing to say we understand, and all of the panelists here deeply understand, that we live in this larger environment, in this larger context, and the workforce issues actually aren't just in healthcare. And we've all had that conversation or experienced that or have listened to those national conversations about workforce shortages are everywhere. Burnout is in many, many places, and it's going up. So with that, what I'd like to do is I'm going to back up. I'm going to first hand it off to Elizabeth Landsberg, who is, you saw her title earlier, but she'll introduce herself a little bit more. And we'll hear about this state agency, HCI, and all of the good work that they've been doing, and what they're looking ahead to do. So a few minutes of that, and then Elizabeth.
Thanks very much, Sunita. Good afternoon, everyone. Happy to be here to talk to you all about healthcare workforce and the work that we're doing at HCI, the Department of Healthcare Access and Information, formerly known as OSHPD. So I always like to start with our mission statement, and every word is important to us, but we didn't, so I skipped over our mission statement. Okay. Well, I don't know. Our mission statement's not here. Our mission is to ensure affordable, quality, equitable health care through resilient facilities, actionable information, and the healthcare workforce that all California needs. We have a lovely visual. I'm sorry that you're not getting to see that right now. In terms of our health workforce development initiatives, yeah, we seem to have sent you all the wrong set of slides, but that's all right. We'll work with it. So we have 3 goals with all of our healthcare workforce initiatives. The first is to increase the racial and linguistic diversity of California's healthcare workforce. We know that health outcomes are better when we have that racial and linguistic concordance that Sunita talks about, and that we have a healthcare workforce that's reflective of California's diversity. Our second main goal is to try to develop the healthcare workforce, specifically in medically underserved areas. People tend to think of that as the rural areas, and that's important, but also there are some medically underserved urban areas that are also very important. I came from a meeting with some hospital CEOs, and they were talking about some of those urban healthcare deserts, and we very much want to help develop healthcare workers for them. And then third, and we try to be very explicit about this, is to make sure that we're building a healthcare workforce to serve Medi-Cal members, and that we're partners with Medi-Cal plans, with FQHCs. We know that more than 1 in 3 Californians has Medi-Cal, and we want to make sure that we're developing a healthcare workforce for Medi-Cal. We at HCI are focusing specifically on primary care, on behavioral health, and we're doing a lot of work in the behavioral health space as well as oral health. All right, some of our healthcare workforce initiatives. So we are working on everything from pipeline to supporting individuals, and then also supporting the institutions that are doing the training program. So we know we can't achieve that goal of racial and linguistic diversity without pipeline or career exploration programs. So we're doing a lot more in that space to try to get folks from high schools, from community colleges interested in joining the healthcare workforce. We're providing financial support to individuals through loan repayment and scholarship. And we've long had loan repayment and scholarship programs. Hopefully you've heard of our Stephen Thompson loan repayment program and some of our other programs, everything from allied health to nursing professions to doctors and psychiatrists. As we look at the reality of the racial wealth gap, we know it's really important to do more around scholarships and stipends and apprenticeships and earn and learn strategies. So we're excited to be adding those tools to our toolbox. So that's really some of the recruitment and retention work that we're doing at HCI. And then we also know that we have to support the institutions. Every nursing program has many, many more applicants than they can support right now. Every social work program. So we're really helping support those educational institutions that are training folks. And if you're on our listserv, if you saw some of our exciting announcements last week, and if you get CalHHS announcements, you saw these. I just want to give a couple specific examples of what we're doing. So in the last week, we announced almost $50 million to 54 organizations to support primary care residency programs. Again, primary care. Almost $60 million in grants to support social work education training programs across 23 institutions. We know we need to build every level of the behavioral health workforce. $61 million to 2,230 students and health professionals in 53 counties, training in advanced practice, nursing, behavioral health, and allied health professions. So those are all folks who have a service obligation to work in one of those medically underserved areas and to work with underrepresented populations. HCI can't do it alone. We have wonderful sister departments. A couple of examples: the Department of Aging awarded almost $90 million in grants to support training for direct care workforce. We know that's a critical need right now. DHCS made $18 million in grants last week available to help students gain practical on-the-job experience in behavioral health careers. So please know that the state of California knows whether you're a Medi-Cal health plan, whether you're an FQHC, we know you need more healthcare workers, and we're working hard to build that. The budget bill that changed HCI's name from OSHPA to HCI also created a new Workforce Education and Training Council. As we were working on our recast and our graduation from an office to a department, read very seriously the Future Health Workforce Commission report. And one of the recommendations is we need a statewide entity that's looking at statewide strategic needs of healthcare workforce. So we're pleased to have set that up. We have 18 wonderful members. Sunita and Health Force are helping us with that process and really looking at what are the needs, what are the innovative ways we can be building California's healthcare workforce. We also created, not on this slide, the Health Education Research, or the Research Data Center. Again, one of the Workforce Commission report recommendations was that we need to have a single source of truth for healthcare workforce supply and demand data. And we will, in the next few days, be releasing our first report. It's a baseline report. It doesn't have everything we need, but we're really pleased to work with the Department of Consumer Affairs and get new baseline data on 16 healing arts boards and their health professions. And then a couple of initiatives I want to mention. One is the Children and Youth Behavioral Health Initiative. So the governor has a vision to really reinvent the behavioral health continuum from birth to age 26, and HCI it's a $4.7 billion investment to reimagine that behavioral health network, and HCI is working on the behavioral health workforce components of it, including creating a new wellness coach. If you haven't heard about that, please join our listserv and learn more about that. And then, very importantly, we're part of the reproductive health initiatives to try to meet this difficult moment. So there are a number of components on the reproductive health care package, including uncompensated care and practical supports and clinical infrastructure security, but also workforce to make sure we're training enough workforce that can provide reproductive health care services, including abortion, in the state of California, given the huge need there. All right. Really wanted to focus today, so again, we're working on many different spaces in terms of healthcare workforce, but really wanted to focus today on our work on community health workers and promotores. So many of you probably know that Medi-Cal now, starting in July, community health work is a billable service to Medi-Cal, and we're taking the baton from DHCS that got federal approval for this new Medi-Cal benefit, and we are taking it to develop a process for community health worker promotora certification that will enable the billing of community health worker and promotora services. So some certification requirements are already dictated in the DHCS state plan amendment, including lived experience that aligns with the communities that they're serving. We heard earlier this morning in some of the workforce panels just how critical that is for building trust, to have community members serving within their own communities. There are also some skills and practical training that are required and are laid out, and a requirement of field experience. And then lastly, a work experience pathway, or a grandparent or abuela pathway for folks who have already been working as community health workers or promotoras, to have a pathway for them. So we're outlining the core competencies for this workforce, the training programs, what should the specializations look like, as well as some of the additional training requirements. So our goal, and I heard someone say it again this morning, 25,000. So it is true, the original budget goal was to train, support 25,000 community health workers by 2025. The funding was decreased. Our goal, take it to the bank, hopefully, our goal is to train 15,000 community health workers and promotoras in the state of California. By the year 2028, so it is critical for us to partner with the community for input. So I'll go into a little bit of detail about our stakeholder engagement process and what we're able to do. I do need to note, generally, folks are probably aware that the state of California does have a significant budget shortfall that's expected this year of $22 billion. So there are some proposed delays which will have an impact on the work that we're able to do. The good news is that the $20 million slated for this fiscal year, that is not proposed for any change. So we are going to continue with our stakeholder engagement process, developing the core competencies and training requirements for the certificate program, but there is a proposal to delay $120 million for next year that was key funding to support community health workers who work in the communities, to support that training program. So as always, we'll need to see where the revenues stand in May and where the budget discussions between the legislature and the administration closes. So having community health workers be reimbursed benefit under Medi-Cal is very important, but of course we know that there are going to be many community health workers and promotoras who aren't going to work under Medi-Cal, that are going to work in the community, work in community-based organizations, and it's very important to us to provide support for their training and for their work and for their field experience. So I'm probably getting close to time. Do just want to say the stakeholder engagement is critical. So we started with some one-on-one stakeholder interviews. We're in progress, some in-person feedback sessions, online feedback sessions. Really want to hear from you. So we do include this email address on our website. Please, if you have a perspective to share about what the training requirements should be, about what specializations we should look to, we really want to hear from you over the next 3 months. It'll be an iterative process where initially we're just gathering information, then we'll start sharing some proposed modalities, but we really want to do co-design with you all in the community. So we have some in-person sessions, some online sessions. I was able to listen in on part of one yesterday. I know Maria and others are helping get the word out about those sessions because we really do want to make sure that we are hearing from folks. So again, this is just some additional information about the sessions. We will have some in-person sessions both in English and in Spanish. If you have folks who want to participate in other languages, please let us know. We want to make sure it's accessible to all. So that's a very quick overview of some of our health workforce development approaches and focusing on community health workers. And with that, I will turn it over. And so pleased to be here in conversation with all of you.
Great. Thank you so much. Is this on? Yeah. If you came after we started the session, welcome. What you just heard was the numbers are huge, both the numbers of who is needed and the different strategies. And so I think you've done a nice job of encapsulating that what HCI is uniquely positioned to do right now is to address issues that are very specific parts of the pipeline, specific groups of healthcare workers, and to move it in a way we've not been able to do so at the state, which is fantastic. What I think Maria Lemus will do next, and she'll introduce herself, is talk about taking that deeper dive. What does it actually look like to get to here, which has been getting to the place of recognizing healthcare workers who've been under or recognized or overlooked. So Maria, let me hand it to you.
Thank you. very much, and thank you for inviting me to be part of the panel. It's exciting to be here today. Jane, I love that you're smiling at me. I want to call out Jane because I want to talk about who we are promotores. And way back 23, 25 years ago, when we first started coming together and talking to each other about wanting to share information, we found that in the Bay Area, we were doing the same thing as in Southern California, as in the Central Valley. And Jane Garcia, who's the CEO of La Clínicas, had one of the first promotor groups in the Bay Area, along with Tiburcio Vasquez and some of the other clinics. And what they did was they brought these women together. So promotoras, we use the term, the network of promotoras and community health workers, because most promotores are promotoras. And so we call them promotoras, in case the men are wondering. And we give honor to who they are, but also it's an equity issue for us that we really want to highlight the great work of women. So if you think about who is a promotor, think in your family, if you have an aunt or a grandmother who's always helping somebody, taking food, giving rides, going out to the community and bringing information back. For me, that was my mother. And she was from Mexico. She had a 6th grade education, but boy, that woman could hustle, and she brought things, and this was in segregated America where the blacks were on one side and the Latinos on the other and the whites on the other. And she brought things to us. So I learned the power of one person. How did I know that many years later I would be here running a promotor organization of women like my mother, like my grandmother who's the healer, like all these other women that I grew up with? Everyone has in their family somebody that's like that. And so Visión y Compromiso honors that person, that skill and that ability. Until 25 years ago or so, it was mostly a volunteer position. They were affiliated with churches or they did it on their own. With the advent of AIDS, I think we had the CHOW, Community Health Outreach Worker. That started to formalize the position. And then with the popularity of including promotores as part of diabetes education and outreach, APHA took it on, and public health embraced it, and before you knew it, wow, here we are. We have a community health worker special interest group at APHA. But what happens to us? And I show you this picture because we are a very diverse community. We're younger, we're older, we're Afro-Latina, we're young, we're from many countries. We're a very diverse community. As a community of promotores, we represent our home countries. We represent also native-born English-speaking Latinos. So the community of promotores is diverse, and it's also founded on what we call the community transformation model centered on the promotor, which we believe that if we continue to give information, education, and training, that person, like my mother, will be the best educated, the best informed person to go out into the community. They will change because of the information. They will change their families, and they will change their community. And that's what we've seen over 25 years. We've seen this change. This is a sounds simple, but when you think of the training department that we have that continues to train about topics that they want to know, that are important to their family. Promotores look at a family in a socio-ecological approach. We don't look at it as it's only diabetes, or it's only hypertension, or it's only aging, or it's only a young person or birth. We say that there's a space of promotoras from preconception to death. If you think of the continuum of life, there's a space for us in every place. And that's important to say that as we talk about categorical funding, and we talk about where we are now, and where are you going to integrate the promotor model? We're not there just for education and outreach. We can do navigation. COVID has shown the importance of promotores in the community. Essential workers, that's what they call us. Well, we've been out there forever. We've always been essential. We've always been important, and now we're recognized. The importance of that is now, how do we continue that thread? How is it that we integrate the model? This is an example of some of the programs that we have. You'll see me on the right with the white shirt about 25 years ago. Yay, I was young with short hair, I know. I think that's when I met Lupe here. I met her about 25 or 30 years ago. This is some of the programs that we have. We have programs for older adults, for young children, for families. And I stress that because as we're looking at the integration of the model across the state, it's not just health, it's not just physical health, it's wellness, it's behavioral health. We're not clinicians, but in this example of the exercise, we have, for instance, a program called Bailoterapia that they wanted us to develop because in there you have nutrition, you talk about how to cook your food more healthy, you have exercise that's appropriate, and then you have talking groups afterwards. So we do a lot of things in the community. When I say we, it's the royal we, but it's we, all the CBOs that are in the community, all of the small and medium-sized agencies that do amazing work that aren't recognized for it. And so part of what we're asking as we look at moving towards a healthy and dignified life, which is what this says, we really want you to look at us as a resource. We want you to look at us as part of the solution for these 15,000 promotoras and community health workers that have to be hired. But in order to do that, remember unintended consequences. My mother, who didn't speak English, who didn't have a degree, who came from Mexico, probably cannot be hired by a plan, a clinic, or a hospital because of the requirements. So that's an unintended consequence. But what if we fund all these CBOs that work with promotores, and they're able to hire the promotora because they don't have such strict requirements, and they're able to pay a living wage, and they're able to offer benefits, and they're able to offer retirement. Imagínense. These women work for stipends, they work for gift cards. Would you work 8 hours a day for a gift card for $50? And yet we expect to do that with them. And so we are advocating that they really be considered a workforce. And part of the 15,000 that we want, expand the vision of workforce. If I was diagnosed with diabetes and I walked out and they told me to eat better and exercise, but I couldn't afford a gym, there wasn't a safe place for me to exercise, and I didn't know how to translate my food healthier. But I had a program like the one that we have or like the one that's down the street from me, and it was funded. And it had the resources, and it had promotoras. Then I could go and I could talk to somebody like Lupe. I could hang out with Lupe.
Yes.
Right?
Yes.
And Lupe would take me by the hand and she'd go walk with me. She'd say, Maria, come on, get out of the house. Let's go for a walk. And I would do it because I relate to Lupe, and I could go walk. Or I could go I could go watch baseball, which is how Jane and I met. And our children played baseball together. And so there's a lot of commonalities, and I think for me, the discussion is how do you expand the opportunity to embrace this army of promotoras that exist? We're everywhere. And we're not just Latinos in the African American community they call sister friends. Every community has us. So think of ways to break down those barriers. Think of ways to include us. Unfortunately, the community health worker benefit is limited by its approach to Medi-Cal. And so most CBOs are not able to, are not Medi-Cal providers, are not able to get reimbursed. I'm hoping that we'll be able to find a solution for that. I don't know that the only solution is for us to become Medi-Cal providers, to tell you the truth. It's an option. It's a big one, but we're working on it, we being the community. But there has to be other options for us so that we can include community as a real player and what we have always been, which is a solution to the problem. Thank you.
Fantastic. Thank you, Maria. And now I'm going to invite Lupe Alonso Diaz to talk to us perhaps about primary care physicians and how do we actually get the diversity we've so long wanted.
Thank you. Thank you, Sunita. And it's always really hard to go after amazing women, and especially Maria, so thank you very much for putting me at the end. Usually I go alphabetically, Alonso with an A, so I feel like I should have gone first, Maria. You know? Lupe Alonso Diaz, President and CEO for PHC. I'm going to tell you 2 quick stories because I really want to get into the dialogue and into the conversation with all of you. 2 very quick stories. One is that my son, my little Zaki, and those of you that know me have heard plenty of stories about Zaki. I'm looking at Mike and he's like, yeah, I've heard so many stories. Zaki supervises me when I work at home, and he's 7 years, he's 8. He just turned 8, and all of his physicians, his neurologists, neurologist, his surgeon when he broke his arm at the age of 3, his primary care physician. He's just had a lot of physicians. They've all been females. They've all been women, I should say. They've all been women. And so one time, he must have been like 5, and we were going to do a service project at school. And he turns to me, we're at the doctor's office, and he's just playing, doing his thing. And then he turns to me and he says, "Mommy, can I be a doctor?" And I'm like, "Sure, of course." And I asked him, "Why, baby?" And he's like, "Well, because I don't see any man doctors," you know? And I love it because I want to have the same conversation. No offense to the European, Anglo-Saxon folks in the room, but I'd love to be able to have that conversation about, like, can white people be doctors? You know, so that's one story. Speaking of Anglo-Saxon, European folks, again, no offense, think of the whitest person you've ever met. Maybe light-skinned, not anybody in this room, light-skinned, maybe even, you know, red-haired, didn't speak a lick of any other language other than English. So that was our primary care physician. My parents were farm workers. They came to this country undocumented. Were farm workers, worked up and down the stream, lived in San Diego, and our Medi-Cal doctor was Dr. John T. Madden. If you Google him, you will not find him because he just has no social media presence, and rest his soul. But he was probably the whitest person that I've ever met in my entire life. But his corazón, just like the corazón that we see here and across the room, his corazón, like his heart was in it. And he became a Medi-Cal provider to the hotel employees, to the hotel workers, to the farm workers, to the people working at the restaurants. He was their physician. And the thing that made him different is not cultural competency, but humility, the cultural humility, the responsiveness, the recognition that beyond being competent, because no one goes to medical school to be competent, you go to be like the best of the best. And that's across all professions, not just physicians. And so he really came into the practice of, like, for the love of medicine, for the love of people. And so this whitest doctor that you can possibly imagine was probably one of the best darn good Medi-Cal physicians that we've ever had, because he took the time to really understand his community. So in the larger conversations, when we talk about some of the, challenges as well as some of the opportunities, and we'll talk about some of the barriers as well as some of the opportunities, but definitely thinking about diversity and also recognizing that, as one of the speakers said yesterday, the conversation now is less about access and more about quality and equity and how do we get there. And so for the California physicians of color, as well as for just in general other health professions, this is definitely a path that is where we desire, where we need to have more diversity. And so I'm pleased to recognize that in partnership with other state agencies like Healthcare Services, the University of California, and CDPH, we consider ourselves good partners to good government. So we work really closely with a number of different state agencies to support and invest in communities that are underserved and underrepresented. And so as we start that conversation around what are some of the barriers and what do we do, the diversity, the academic pathways, the financial support, like, let's recognize that, whether we're talking about the nursing profession or a mental health profession or a physician workforce, that it takes money, it takes an investment. And so when we talk about, as an example, physician recruitment, we always, joke that it starts at the womb, but it really does. Maternal health matters. And when we have maternal health, when our women, when our pregnant persons have access to those, to all of the wraparound services, where they are and where we meet them, where they are with the people that look and understand them and speak their language, when we can figure out the maternal health piece, the rest of it doesn't get easier, but the rest of it does get a little bit easier. So definitely when we talk about diversifying the workforce and diversifying primary care physicians. Yes, it starts with maternal health, and it also starts with recognizing that whether it's financial support like loan repayments, which HCI and both PHC have in common, whether it is academic pathways, which HCI has with respect to really creating those academic opportunities and really investing and supporting our students as they go through the process and giving them financial resources in real time. Love loan repayments, but if that opportunity was there to provide it in real time, I think that that would definitely address some of the issues. And then I know that we'll eventually also talk about burnout, and I think that we're all there. We're all there, regardless of what our situation was. It's been a traumatic experience. It's been the best of times. It's been the worst of times. And I know that for myself, working at home, it was the best of times, and it was also the worst of times. Distance learning was no joke when you've got a kindergartner, in the room who wants to, cut his hair, or whatnot, wants to have, or cut mine for that matter. So, so I'll end just by saying that I appreciate all of you being here. I think that it definitely takes a village. It takes a village of all of us to, to figure out how to move this forward. Back to Sunita's comment, there's a lot of bright spots, not just in terms of these programs, but generally. I think that I'm thinking about, one of my, I'm not going to say old, one of my former bosses, Kim Belshea, who I see, and she used to say, just speak truth to power. And she also used to talk about good government, and that good government exists to solve problems that don't necessarily get solved in the private sector. And I very much believe that. I believe that it's a partnership. It's a partnership of different entities, CBOs, government, private enterprise. So I'm looking forward to those conversations.
Great, thank you. I'm going to suggest, if you guys are open to this, that we just go ahead and open it to conversation, and then we'll come back with a closing question around strategies to elevate. So, all right. I think, why don't we start here, and I'll just work back. So, 2, 3. Okay. I think there's a mic if you need it, or please stand up and face the audience. We can hear you.
Hi, thank you so much again for sharing your wisdom and your passion with us. This question is directed to Director Landsberg. Is there any emphasis or training provided by the state towards literacy, particularly health literacy? And maybe thinking out loud, would community health workers and promotoras like Director Limas assist in addressing this issue?
Thanks very much for the question. So in terms of upskilling with literacy, we are definitely trying to support at every level, bringing some new folks in to the workforce. With Pipeline, I don't know that we exactly have literacy programs that we're supporting, but I do want to just talk about the career ladder that I think all of us believe is important, and part of the work that we're trying to do is make sure that there are opportunities for folks at every level, and that we can support folks on the way up as they want to upskill. So Lupe talked about that we can't just provide financial support, but that we need to really do wraparound services, provide mentoring to folks, not just recruit people into the profession, but also what support and mentorship are we providing. I have my laptop out because I wanted to call out a particular program that, so I told you we have this health education workforce training council, and we've had some wonderful conversations and panels about how do we bring new folks into the behavioral health workforce, into the nursing workforce, and we had a wonderful panel, and Al Roulette from Turning Point Community Programs, who serves 10 counties in Northern and Central California, talked about their own pipeline program. So they created a barbers, beauticians, baristas, and bartender program because we talk about this. There is the Great Resignation, and there are workforce shortages. We know there are a lot of people who are working in retail, who are working in fast food and other service categories, who have lived experience, who have a lot of emotional intelligence, who really can meet this moment and help us meet the need. I don't capture it nearly as beautifully as Maria does, what it means to have someone come and help you. And we've all seen those folks who are guides, who do take you by the hand and lead you. So we we have to, I think everyone here think creatively about how do we reach those folks. And, you know, there are the jokes about the barbers and the baristas as providing emotional support. Can we bring them informally? So we're thinking about the career ladder. Wellness coaches is something we're doing under the Youth Initiative to identify that we have these licensed behavioral health workers, we have peer support specialists, but we know that youth have told us they want, frankly, younger, much more racially diverse, not peer support, but kind of near peer folks to be providing them with support. So the wellness coach model is based on that premise, folks who will have an AA or a BA, and we're going to support them in working their way up the career ladder. If they want to continue to stay as coaches, that's great. If they want to go on and become a social worker or a therapist, let's provide that support to them as well.
I think that's a great question. Let me just tag on to that I think literacy has always been an American requirement. It is not necessarily a requirement in our communities, and our expertise is founded on our ability to communicate with our own, whatever language that is, whatever culture that is. I'm Chicana, born here, Mexican parents, and so my Spanish is, on occasion. But what is important is the human translation of that. Now, sometimes that will offset the ability of that individual to speak, for them to speak to each other in a common language. But we have found that the only places that you can get literacy, English, to learn English, are the institutions, which is a very difficult place to go. Community college, you'll look at the numbers, and rarely do Latinos attend community colleges at any age. The community health worker certificate programs, typically in community colleges, are not registered by community members, especially Latino community members. So what we've done internally is developed our own path. We have a workforce initiative where we help the individual move through to understand systems, to understand the bureaucratic language, and to be able to function in their own language. And then we have managers and coordinators. We have 2 of our managers and coordinators here who then help facilitate that. So we're trying to bridge that without requiring them to learn English, because their skill is not English. Their skill is really the ability to communicate at that one-to-one level. I think that's one of the barriers that we have, is thinking that's it, along with a high school degree or a BA. I do want to tag on to what you said about the wellness coaches. We have a program that we implemented during the fire season for crisis counselors. They're amazing. They are what you're talking about, and they initiated their 27 across the state, and it works kind of like a 2-on-1. They outdid and outnumbered anything that 2-on-1 does, because Latinos are responding to them. They were out in the community advertising, saying they were available. So if given the opportunity, a group, ACBO, will find a way to reach the community. And I think what the barrier is in all of the state institutions is the mainframe that has existed for so many years. And we have to just adapt it and change it a little bit.
Great, thank you. We'll go ahead and take the next question, and feel free to direct it to one of the panelists.
Hi, Dina Lon, San Francisco Community Clinic Consortium. Good to see some old friends I've worked with in other jobs. I'm going to be real quick because I could talk about this forever, but I want to say something about CHWs, something about social workers, and something about doctors. CHWs, just so you guys all know, we're doing a pilot program that's privately funded, which let us have the ability to kind of experiment. We're supporting 2 or 3 CHW promotoras in each of our clinics doing different things and trying to track their success. But we're also giving them their full-time jobs with decent pay and benefits, but also 8 hours a week that they get specifically to attend classes at City College of San Francisco so that they can get certified. And I just would love to talk more, but or have the person who runs the program talk more. There's a big bridge, even between a community college and a community member. It's too hard to enroll in our local community college. It's too hard to get your damn books. And many of our CHW promotores just didn't have the computer skills, the basic skills to even get on to the very complicated system that the community college uses. So that's just a comment that I just want everybody to think more about, making the bridge between the academic institution and the community health workers. And we're excited when we're going to be able to report back to you in about a year about how much they've accomplished. Social workers, goes for MSTs, everybody else. I don't think loan repayment works. I think if we're trying to recruit people who are maybe the first generation in their family to go to college, the idea of taking out a loan and at some point later to get reimbursed for it and doesn't make any sense. You got to have a better way. We've got to have, and I know there was a bill Senator Wiener introduced, didn't go anywhere, but we've got to have, again, a better coordination between what is going to get people actually out and able to practice without burdening them and jumping through every academic hoop that they need to jump through. My daughter applied to social work school this year, $60,000. $60,000. She's accepted she's never going to make that much money, so how could she take on $60,000? That's just one example. So I really wanted, I think our social work schools need to get on board with really welcoming people in and supporting them as they go through the process and trying to figure out how to make it work financially. Our social work schools are eager to place social work students in our clinics, but there's no money for supervision. So the other thing I think we really need to work on is we don't have the capacity to supervise people. We were so excited about the mental health nurse practitioner program that the UCs are doing. We're like, this is the answer to our prayers because we desperately need people who can prescribe psychiatric medication. We don't have the staff to supervise them, so they won't place them in our clinics, therefore not opening up that piece. So supervision has a cost, and it's a very important cost. And that leads me to my third thing, which is about doctors. We need doctors, primary care doctors, we need psychiatrists desperately. We can have all the loan repayment we want and all the recruitment techniques we want. There just are not enough residencies in California, in the communities. The Teaching Health Center program is great. We're really excited. We're starting one in San Francisco. It has 5 slots, you know, and this has taken us 10 years to get it. So I think that California is so powerful, and we are not advocating enough at the federal level to really change the GME. We just need more people. We need more bodies, and obviously we need more diverse bodies. So that's where we are. I just want to say in terms of community health workers also, we started this project with private funding that was time limited with the idea that at the end our clinics would be able to bill for CHWs, but FQHCs can't really bill for CHWs. It's a big glitch in the system, and one that I'd be really happy to try to work out because it's going to be a real problem when these people end this very nicely funded 2.5-year program and yet the clinics cannot yet bill for their services. That's it. Sorry, I'm taking up a lot of time.
Did you want to?
Yes, please, pick me, Dina. Nice to see you. Couldn't agree with you more. AB 2132 was a bill that we sponsored last year, PHC, in partnership with the California Medical Association, and it completely addresses your point around financial support. The recognition that first we need to identify persons from underrepresented communities and really be creative about what a lived experience is and how that lived experience, whether it's a rural community, whether it's urban underserved, whether it's a language or an immigrant experience, that those things are valuable to how we practice medicine and how we take care of each other. So AB 2132 would have identified persons from those underrepresented communities and in essence made them a promise. The promise would have been, if you get through, and we all know that this is hard, if you get through undergrad, we will work with you to get real-time financial assistance, whether it's through Cal Grants or something else. Then you get to medical school, we will give you a scholarship and a stipend. So the scholarship for the tuition portion of it, the stipend because, oh, guess what, you probably can't work. So again, that really influences who applies for medical school. And that makes a really big difference. The who applies tends to be those communities, those families who have a little bit more affluence and or have the ability to project and make that cost benefit analysis, absolutely. My farm worker parents would have thought that's ridiculous for someone to get a $300,000, $400,000 loan for the promise of maybe getting it repaid. So AB 2132, we're thinking about ways to reintroduce the bill and or something similar. Totally agree with you also on the GME in terms of we just don't have enough graduate medical education physician training slots. I think that both Elizabeth and I have the same experience in terms of administering programs that support GME. And part of the challenge is definitely it's a very archaic federal financing situation, and that's the big dinosaur. It's not even an elephant; it's like the big dinosaur in the room. Is that and so definitely working with the feds on that. There's a lot of really good programs, a lot of good GME programs in California. It takes about $150,000 per resident per year. To administer a GME program, and there isn't enough financial support. On top of, within 5 years, GME programs have to be at their fullest complement in order to maximize their reimbursement. What we do know is that physicians, like other health professionals, they tend to practice, where they were trained, and so the more that we can provide those partnerships with, like the Clínicas, with, Jane's group, with other health centers, with other community-based organizations, the more that we can make those linkages to those other health systems, the more likely we're going to have physicians and other health professionals that'll stay in that area because we've made an investment in them, and they'll do the same for us.
So can I make two comments to that? One is two things that I know are happening. When we look at the pipeline, we're starting at the very, I don't want to say the bottom, but the core of the pipeline. We started training youth promotores in Bakersfield, and we have 2 cohorts. And what came from that is that they now see being a promotor as a profession. Because we hire promotores, we give them a living wage, they have benefits, and they have retirement. And they see that now they have an opportunity to go into that. And I think that's a really important piece as you look at how do you move our youngsters into thinking about health professions. Now, they may not end up a promotor, they may end up going to med school or being a social worker, but it opens their eyes that there's opportunity for them. The other thing is in terms of education and the educational level of promotores, we train thousands, 8, 9, 10,000 promotores in 15 years. We have a curricula. They come every week for 8 hours. They stay. The attrition rate is like 0. They have curricula. They have to do things. They have products. They have projects they have to continue. There is no dropout rate. Promotores are really smart. They may not have a degree. They can't speak English. Who cares? They don't even speak Spanish, the indigenous groups. It doesn't matter. We have to rethink how is it that we're moving these people up? Because there was a first session that we did from NYU, and it was, I forgot what the project name was, and this professor came and taught evaluation to a cohort of promotores, 30 of them. It took him forever, fidelity, blah, blah. By the end of the session, he was so enthused that he partnered with USC to develop an evaluation component for promotores, because they learned it so well. It took a little longer, true, and it was harder for them to adapt to it. But I think we have to remember that these mostly women are so smart that they can learn most anything. And I think that then allows us to move them into different categories. They don't have to all go through academics. They can learn in other ways. We have modules, for instance, and that opens the door then for upward mobility if they want to go into another sector of health.
Great. There was one more question. Yeah.
My name is Michael Kusinov from Los Angeles. So during the pandemic, our local health department, LA County, struggled with the public health workforce, particularly around contact tracing and other core public health functions. They literally didn't have enough people to do. So we were, taking people from the libraries, from any place where, we could train people. And so I haven't heard much about how we train, what do we do about the public health workforce going forward, particularly working in the public health departments? I want to know, Elizabeth, if that was part of your plan or there's something else that some of these other groups can be focused on a little bit.
Yeah, thanks for the question, Michael. It's very important, and we certainly know during the pandemic it was all hands on deck. I mean, HCI, as well as every other state agency, had staff on loan to work on contact tracing, because you're right, we just couldn't find all the folks that we needed to do that very important public health work. So our core work is not focused on public health, but the California Department of Public Health does have some workforce programs that are, you know, everything from, you know, some specialties that we just don't cover. So there are definitely investments being made in public health workforce, and it is a critical need.
Great. Let's do this. Let's talk about the strategy. So maybe one thing that you think should really be amplified or is ready for scale that will help contribute to meeting some of the workforce shortages, and I'll go in whatever order.
Well, since
Lupe,
Lupe got one last,
Lupe, if you want to start, and then I'll come to Maria and Elizabeth.
Actually, I was hoping for the opposite, so thank you, Elizabeth. I'm just kidding. Elizabeth and I are also friends, in case you didn't realize that. I would say that we need to think about the whole journey approach in addition to the whole person approach, and what that means is if we reverse engineer and we look at what the outcomes, what is it that we want? We want a diverse, culturally dynamic community. Then we have to reverse engineer, how do we get there? And so in addition to the partnerships, it requires, in my opinion, that holistic approach of like the academic or career lattice, the financial support, the social support as well as the recognition that burnout is a real thing, and not just for existing health professionals, but for students and for individuals going through the process. And that also includes even little 5-year-olds that went through distance learning when they were in kindergarten or 5th grade. And so it's a recognition that we need to think about mental health a little bit differently, because we all need it. We all need that socio-emotional support in addition to other mental health services. So I would say just thinking about it from a whole journey approach with the academic, the social, and the financial supports.
Great, thanks.
There is an army of promotoras out there. They are ready, they're well trained, and they're ready to engage in work, either as an employer or to support other agencies. California is blessed. I think we have probably the largest number of trained promotores, trained through CBOs, who can function really well in the community, who are experts in the community. I sit on national advisory committees. I'm one of the founders of the National Association of Community Health Workers, so I know kind of what's out there. California is far and above what other states are in recognizing the value and the importance and the skills of promotores and community health workers. And I think this is an opportune time for us to figure out a way to integrate those who already have the skills across sectors, not just in health, but in behavioral health. We have a family, friends, and neighbors, childhood. We're working on a project for death and dying and Alzheimer's. We have a space everywhere. And I think it's important, we're modeling it as an agency, but we want agencies to look at what the community is doing and how can we integrate all those wonderful programs that exist out of necessity. Because the promotora comes to Sanita and says, I have this problem. My child was born in the spectrum. Forget, the spectrum. What do I do? So as a promotor leader, she says, well, let me find out the resources for you. And before you know it, we have a curricula and a program. That's what exists today informally across California. How do we integrate that? We have not just an army of promotoras, we have community leaders, we have CBOs that are living off of a dime, that are doing so much work that I can't even tell you they're doing so much work in our community. And so we have formed a group called La Alianza, which is community-based organizations, to support them to advocate for funds to go to CBOs, and so that they can hire promotores, so they can be an example of what exists. So I think if I would say anything, it would be look to your community experts, look to your CBOs. If you don't know one or have one in your area, we're happy to refer you and to help you. Help us grow the field of community experts. We're already there. We're already helping. Let us formalize that and be that dotted line to the agency, to the clinic, like the promotores were the dotted line to Jane and to Tiburcio and to many other clinics. So I would say, not take advantage of us, but let us be your partner.
So it's really humbling to be up here with all of the three of you. And I guess I would echo some of what Lupe said about just needing a holistic approach and all hands on deck, right? So I can't just point to one strategy necessarily, because we have to have short-term strategies and long-term strategies. We know hospitals need nurses now. We know, as Dina said, we need more doctors and psychiatrists. And it takes a long time, right, to train a psychiatrist. So we do need to start now and reach kids. And, as we've mapped the medically underserved areas and the places where we have these workforce shortages, and they're the same. So part of it is literally about getting the advanced science classes that folks need into communities that are medically underserved, and then providing support all the way up. So we're really excited to try to delve into every level of the primary care and behavioral health workforce needs. The last thing that I'll just end with is the need to really continue to center equity. And so we talk about needing to diversify the racial and linguistic diversity, and that's different for every profession, right? I mean, as Maria said, the promotora workforce is very racially diverse. It's women of color who are underpaid. So there, our equity approach should be, how do we lift them up and how do we pay them properly, which is very different for doctors, where we don't have enough Latino doctors, and we don't have enough women psychiatrists. And so trying to have a focused approach. So we have those goals, and we're gonna be undertaking a process in the next year to really see, with our application criteria, are they narrowly tailored and most effective at meeting the goals that we want, and starting to ask things of the workforce, the GME, the schools that we're supporting. What are you doing to counteract bias? What are you doing to have an anti-racist curriculum? And what can we do to really most meaningfully further our equity agenda? There's been very important work done by California Healthcare Foundation about the different experiences of Black Californians in our healthcare system. We have to have a focused, tailored approach to address some of those disparities and realities for patients.
And I would say that all that starts in elementary school. When a high schooler in one part of town at an all-Latino school like in Ridgeland High School doesn't have enough AP classes, well, that, it just started in 9th grade, it started in 7th grade, it started in 3rd grade when they start testing you. It's such a long process that the investment has to start early from infancy. Is that parent stressed out because they don't have enough food on the table, that because, things are happening in their house and the child feels the repercussions of it? It's such a complicated thing, Elizabeth, I agree. But to take a multi-pronged approach and starting with our families and how to support them so they can support the children who have the aptitude. Not everybody's gonna go to college, but my mechanic makes as much as a doctor, I think. So, a good living can be defined in different ways. And how do we offer that opportunity to our families and to our children?
It is impossible to try to summarize this in one thing. I'll say a couple of things. I hope what you took away is that there is a lot of action and activity that's going on. Some of it is coming at the state level. There's a lot going on in communities, and I think really trying to identify where those are and connecting dots. What I think this panel also does, and some of you talked about this, and some of you I know are doing this, which is coalition building. I'm going to take off of a theme from earlier today in the panel, that this is one of our challenges, is that we silo to try to solve the problem alone. I need, fill in the blank, you need, fill in the blank, and yet we actually all have shortages. And what we're doing, unfortunately, often is we're taking from each other, which is not bad for the individual who might benefit from pay increases and ladders and lattices. It does not serve our communities well. So the advantage right now, perhaps, that we've never had is this deep investment of actually trying to lift and do a lot of taking evidence that we have already built and apply that and fund that and test things that we don't know about that might actually work. And the last thing I'll say is we haven't touched on burnout. I will say that is, I'm going to get on my soapbox for just a moment. Burnout is not the problem of individuals. It is our systems that have created that burnout. So the solutions are not with individual clinicians, providers, community health workers. They are with the systems in which they work. And I think that there are some solutions. There is definitely a lot of national effort. And that to me is really exciting because the ability then to do something is so much greater than picking off one person at a time and saying, how can I help you be less burnt out? So I hope you leave on a hopeful note. I know I do, and I know we're going to go to another session soon. So please join me in thanking this amazing panel. Thank you so much.